All right. So my name's Stephanie Garner, and I am the program coordinator at Down Syndrome Indiana, and really excited that you guys are able to join us today. We are here for our second to last week of our annual conference, which is Promoting Independence for Life. And we have Dr. Cassie Karlsson, who is with us tonight. She's going to be talking about the trouble with transitions when mood and anxiety symptoms get in the way. And Dr. Karlsson is an assistant professor of clinical psychology with the IU School of Medicine. So we're excited to have her. Before we begin, though, we are going to cover just a couple of housekeeping items. So we want to thank our sponsors, About Special Kids, Family Voices Indiana, Mass Mutual Midwest, and Mr. Gordon Holmes, and Shepherd's College. And we're going to share this short video from Shepherd's College, which is our feature sponsor for this evening. Well, maybe. Let's see if I can figure out how to play it. Well, we might have to share that at the end because it is not playing. I apologize. Shepherd's College is a really cool program up in Wisconsin. You can check them out and learn more about their organization and watch that video that I'm struggling to get to play by going to our virtual exhibit hall at www.dsindiana.org /virtual-exhibit-hall, and you can hear from all of our great exhibitors. They've got contact information, and a lot of them have shared a short video clip that tells you a little bit about their organization and why you might want to get in touch with them. So without further ado, we will go ahead and hand things over to Dr. Karlsson.
All right. Let me share my screen here. All right. Well, I really appreciate being invited to speak at this conference. Some of you have just joined. We were talking in the first couple of minutes before it started that I'd been excited to be invited to speak at last year's conference, and unfortunately a few days beforehand had to email Stephanie and cancel when an emergent situation came up. And then when this year's conference was canceled, I was starting to feel like bad luck for the conference. So I was really excited that we were able to transition this to virtual, and that I get an opportunity to talk with all of you about something that I'm very passionate about in the clinical work that I do every day. So I am both a adult and child and adolescent psychiatrist, boarded in both, and I specialize in seeing children and adults with neurodevelopmental disorders. In early 2018, I think it now was, I'm trying to remember, I started a Down syndrome clinic in our Department of Psychiatry, which has really grown over the last several years, and have gotten to work closely with the Down syndrome clinic in developmental pediatrics and with several other Down syndrome experts across the country in developing this clinic. And I'm looking forward to talking with all of you guys today about some of the trouble that we see with transition and some of the symptoms of depression and anxiety in both adolescents and young adults with Down syndrome. So full disclosure, I never took an art appreciation class in college. A lot of my classes were in biology and other sciences, but I really love art. And one of the things that when I was starting to think about transitions is I was looking online, and there are a lot of pieces of artwork that are titled transitions. And it's interesting because many of them are very, very different. So if anybody is really into art or an expert or has taken art appreciation, I apologize for anything that I may stumble over here, but I thought there were some interesting things when we looked at a few different paintings that are titled transitions. So for example, this transitions artwork, I look here and I'm like, oh, there's a very clear path here, you know, things changing over time. I can maybe say here's some changing of seasons. For those of us that are parents, probably especially mothers, we're a little worried that it's looking a little dark back there in the woods, right? What could that be? But overall, we can see why this is maybe titled transitions. Here's another piece of art titled Transitions. Looks a little dark and gloomy, maybe not quite as clear cut. I was excited to see some maybe sunshine poking through back there, but definitely not as defined as the first painting. I'm not really sure what happened with this transitions painting. I'm a little worried maybe it was a bit of a rough transition. But the reason that I'm going through these paintings and talking about this is really the recognition that transitions can mean a lot of different things to a lot of different people. And just some, time to think for all of us, what do normal transitions look like? So a lot of times we talk about the transitional age, and that's what I'm going to be focusing on here today, is kind of adolescents, young adults who are making a lot of transitions in their life. And so for a minute here, I want each of you to stop and think about your high school years, your college years, or your early years after high school graduation. Think about it all, the good, the bad, the ugly, right? All of the changes, all the different things that you went through. So I asked a few folks, what are some words that come to mind when they think about that time in their life? And I don't know if many of you have seen these word clouds that you can generate, but these are some of the words that we came up with when we were thinking about this time in our life. And the bigger the word, the more people reported it. So this is a time when there's a lot of change, right? There's increased importance on relationships, maybe on careers, maybe going to college. Friendship takes an important role, but there's a lot of stress and pressure and lots of different things that are going on. Some of them really great, right? Maybe you've got opportunities, you're graduating, but also you've maybe got more responsibilities. You have to say goodbye to some people. There's some fear maybe associated with it, a lot of unknown. And I think the other, so there's really so much that we go through during this age. And it's important to note that really the onset of many psychiatric disorders in the general population tend to occur during the adolescent, or first occur during the adolescent and young adult years. And this is also thought to be a combination of biological factors, psychological factors, and social factors, including some of the stressors that we see up here, related to a lot of the words in this word cloud. So when I hear things like trouble with transitions, I'll hear that a lot, so-and-so's having trouble with transitions. And it's a little different than kind of, it's a hard transition off the school bus, right? What I hear maybe in my younger kids, but we're talking about kind of these really big life changes. Maybe we're graduating from high school and we don't have the structure of school anymore. Maybe we're starting some volunteer work or some supported employment, or going to college and taking some classes and things like this. But leaving our structure, maybe leaving some of our friends that we've had, maybe moving out from mom and dad's house, having a different family situation. And I think there are some important things to remember, is that as we were talking about with the paintings, transitions are really different for everyone, right? Everyone has a different path that they're following. They'll have different experiences. They'll have different things that go well and different things that are more challenging. The other thing to remember is that change is hard, and really having some struggles while you go through change is a part of normal development. And it's actually really important for our developing brain to have some of these stressors and to work through it and figure some things out. The other important thing is that everyone is entitled to a bad day. And if you think about maybe in your own lives, in your own careers, when you're having a lot of change happen, it's stressful, and maybe we find ourselves being more irritable with our loved ones. Maybe we're not getting as much sleep because we're staying up late and worrying. And that's going to be normal, right? And doesn't necessarily indicate that more is going on. The other thing is that in terms of anxiety, everybody's got it. So this is actually evolutionary, that anxiety is part of being a normal human being, and it's there for a reason, right? It helped our ancestors escape saber-toothed tigers. It keeps us safe. who, no one would look both ways before they cross the road if they didn't have any anxiety. So it's important to know that anytime there are new things, there are unknown things, it's part of keeping us safe to be a little bit anxious about, maybe I should be a little suspicious, a little cautious until I know more about what's going on. I think for all of us that are parents, we really have a lot of experience figuring out what's going on with our kids, right? So from the time they were very little to this is what this cry means, this cry means they're hungry, this cry means their diaper's wet. We've been figuring out our kids. And a lot of times when I'm talking with parents that they feel like their child is struggling with some of these transitions, there's that kind of gut feeling that maybe there's more than what's going on. But I think, like I said, a lot of this comes from experience and that we all know our children best. And I don't know if any of you guys have seen those memes that get shared on the internet called "Why is my toddler crying?" But I find them very, I don't know, it's one of those things, they're so true, you don't know if you want to laugh or cry. But for example, why is my toddler crying? Because she's not allowed to eat batteries, right? Typical maybe 18-month-old response to taking batteries away from her, right? I wouldn't let him eat the pool noodle. Her granola bar broke in half, right? And then the last one, the egg carton just wouldn't go in the Lego box any further, right? So sometimes as parents, we've become accustomed to these changes. And so we kind of know that, you know what, my child has not gotten a lot of sleep this week. There's been a lot of increased expectations. My gosh, they're just getting over being sick. I think that's what's going on. And so I'm going to give them a little time to kind of work through this. But I think that there sometimes reaches a point where we then ask ourselves, when are these struggles more than just normal adjustment, right? So when do I need to be worried that maybe something else is going on, that perhaps my child needs some additional help, or I need some help knowing how to support my child through this difficult time? And, that's when we start thinking about psychiatric diagnoses. And some of you are probably very familiar with this book, the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition. When I was training, it was the DSM-4, and then it switched to the DSM-5 right as I was finishing my training. So I remember being very frustrated that I learned the DSM-4 and now I had to take my boards in the DSM-5. But one thing that you'll notice in a lot of these diagnoses in here is that there's a huge spectrum to kind of the human condition, right? So I've just told you, and everyone recognizes people can have bad days. People, everybody has some anxiety. I'm going to guess that there is, all of us have at least one thing that we're a little obsessed about, right? What makes things a diagnosis or a disorder is really when it's above and beyond some of these normal, everyday, normal range of emotion that we experience, and really is significantly impairing functioning. The 3 that I wanted to focus on today in our talk is major depressive disorder, generalized anxiety disorder. There's a lot of different types of anxiety, and we can certainly talk about some of that, but I wanted to focus on this diagnosis, and then obsessive-compulsive disorder. So these slides, I'm not going to read every word, and I know that this is going to be posted later and people can go back and look, or they can Google these diagnoses. But I wanted to point out a few things of hallmarks of these diagnoses. Of when someone comes into my office, whether they have Down syndrome or any other, diagnosis, I would be looking at this if they're reporting some of these symptoms to me, and this is what I would use to see if they meet criteria for major depressive disorder. So major depression has to be a set of symptoms that are occurring over at least a 2-week period. And at least one of them has to be a depressed mood or a loss of interest or pleasure. And it's important that we know that the symptoms are not attributable to another medical condition or another psychiatric illness. And we'll talk a little bit more about that later. So you need 5 or more. of these symptoms. And so the first one is depressed mood. And I think it's important to note that a lot of times in children and adolescents, as well as individuals with neurodevelopmental disorders, sometimes that actually presents as an irritable mood rather than the kind of down and depressed mood we think of when we think of depression. A really markedly diminished interest or pleasure in the things that they used to enjoy, like maybe the movies they liked, or they really loved playing on their iPad. They're not doing that anymore. They really loved playing music. They're not doing that anymore. A change in weight, both loss or gain, that's significant, or a decrease or increase in their appetite. And these are things that are happening not just a couple of times in the last few weeks, but these are all symptoms that are happening really nearly every day for at least the past 2 weeks, and quite honestly, often more by the time people are seeking evaluation. Either insomnia, trouble sleeping, or sometimes sleeping too much. What we call psychomotor agitation or retardation. What that means, agitation can be, kind of feeling restless and, maybe a lot of pacing or things like that. Psychomotor retardation is being more slowed down, which really goes with a lot of the fatigue and loss of energy we can see in depression. Sometimes feelings of worthlessness or excessive guilt, and diminished ability to think or concentrate or solve problems. And for some people that have a diagnosis of depression, they have increased and recurrent thoughts of death. That's not just a fear of dying, but thinking about death, including suicidal ideation. In terms of generalized anxiety disorder, this is the presence of excessive anxiety and worry about a variety of different topics and events that occurs for at least 6 months or more. And it's clearly excessive. So it's not just, oh gosh, I've got a test coming up, I'm worried, about finals, or, I'm worried about some storms that have been happening or things like that. It is really above and beyond and all consuming. So the other thing is it's very challenging to control. So we're not talking about the type of anxiety that we can just redirect and reassure. It feels very pervasive. And this anxiety and worry is often accompanied by at least 3 of some of the following other symptoms. So maybe some restlessness, feeling more fatigued, trouble concentrating, maybe more irritable, sometimes with what we call somatic complaints, right? So complaining of having some pain or muscle aches, soreness, and then also difficulty sleeping. The last one I wanted to cover was obsessive-compulsive disorder. And in obsessive-compulsive disorder in the DSM-5, you can have obsessions or compulsions or both, and they often do tie together. But for example, obsessions are really recurrent and persistent thoughts or urges or impulses that cause a lot of marked anxiety or distress for the individual. So the classic one that we think of when we think of OCD is like a worry about germs, right? Worry about cleanliness, things like that. What this isn't is obsessions about something that someone likes. For example, if someone's really obsessed with the TV show SpongeBob, right? And all they want to think about is SpongeBob, and all the clothes they want to wear is SpongeBob, and all they want to talk about is SpongeBob, that's very different, because that's something that's really enjoyable, right, for the individual. These are thoughts and impulses that cause distress for the individual. Also, there's evidence that the individual tries to ignore or suppress these thoughts, right? Like, I'm not going to think about the germs. I want this thought to go away. I don't like this thought. So compulsions, these are often repetitive behaviors that are done in response to the obsession. So again, kind of with the classic, I have a germ phobia, right? Now maybe I'm going to wash my hands over and over and over again to try to reassure myself and feel better about this obsession that I have that somehow my hands are dirty. So a couple of things about these compulsions. They can be directly connected. Kind of like, it makes sense. If you think your hands are dirty, you want to clean them multiple times a day, and they're just kind of above and beyond what one would need to do to clean their hands. They can also be seemingly unrelated and a little bizarre. So sometimes it can be, I need to perform this ritual so that nothing happens bad to my mom or dad, right? Like I need to sit in a certain way, or I need to put things in a certain way so that nothing bad happens. And those obviously aren't connected, that if your water bottle, someone that their water bottle needed to be a certain way, or they couldn't tolerate that and they were worried about the car driving and related to where the water bottle was sitting in the car, those obviously aren't connected, but there's this real impulse to make that happen, and that worry. The important thing to think about with OCD and classic OCD is that it's really, really time consuming. And so the criteria that we see is more than 1 hour per day. I will say when I see individuals that have legitimate OCD, they are spending a disproportionate amount of their day with their obsessions and compulsions. So this would be someone who maybe has to perform rituals and touch things in a certain way, and it takes them hours to get out of the house, right? Or they're 3 hours late for work because they were washing their hands and couldn't get out of the house, and things like that. So, taking up a significant amount of time. So I think it's important, and really a question that I ask frequently with my patients, especially patients with developmental disorders, and specifically today to talk about, is what do we know about these disorders in Down syndrome? So this is probably not a surprise to most of you that are watching this today, but there's actually a pretty big gap in the research in this age group, adolescents and young adults, in terms of the behavioral and psychiatric issues that occur. We have quite a bit of research in young children in Down syndrome and behavioral phenotypes and things that we see. We also have quite a bit of research in older patients with Down syndrome, especially around Alzheimer's, dementia, things like that. Where we don't have as much understanding is in between, especially related to behavioral and psychiatric issues. So I think it's important to understand, how do we then come up with, our evaluation, how do we do an evaluation? How do we make treatment recommendations? And some of the things that I wanted to talk about that I think commonly occur, and I am imagining many of you in the audience have heard the phrase, well, this is just the Down syndrome, right? That is just what's going on here. And the worry that I have when I hear that, and it's, I think, frequent from healthcare providers, from people in the education system and things like that. And while not meant to be, a negative phrase, my worry is that sometimes when we are attributing things to just the Down syndrome, we're missing other things that can be treatable. And I also feel like sometimes when this phrase is said, it's really kind of like, well, there's nothing we can do about it. Right? And for a lot of the concerns that come up, there are a lot of things that we can do. So I wanted to point out a couple of reasons why I think this happens. So there's something in the medical literature that we call diagnostic overshadowing. So this is kind of when we attribute basically all of the behaviors either to the fact that they have this disability, and we say, well, it must be because of that, right? Well, they have these obsessive behaviors, or they, react this way because they have because they have Down syndrome. Conversely, it could be that everything is attributed to a psychiatric disorder without acknowledging that they impact each other. So a common one that I see here would be ADHD. Right? So where it'll be like, well, they're having trouble concentrating. Well, it's because they have ADHD. Well, they maybe also have anxiety, and it's really hard to focus and concentrate when you're worried about something, right? Or maybe they have an undiagnosed learning disability, right? So that's why they can't concentrate. Maybe there is a speech and language disorder, and that's the reason they're having trouble paying attention and participating in class. Kind of like, if I was giving this talk in Russian, probably a lot of you guys would look like you had ADHD right now. And so it's really important that we are considering all factors when we're making a diagnosis. The reason this is really important is that we know that there's a high co-occurrence in individuals with intellectual disabilities with psychiatric disorders. And there's been some estimates that up to 40% of individuals with intellectual disabilities have clinically significant levels of behavioral or emotional concerns. And so it's really important that we're not just attributing things to, well, this is just related to their intellectual disability and there's nothing we can do, because there's often a lot that we can do. And if we're not diagnosing these things, and if we're not exploring ways that we can intervene, we're ultimately really potentially impacting overall quality of life. And I'll talk about that in a bit. So when we talk about what we know about psychiatric disorders and Down syndrome, we know that there are some disorders that we seem to see more often in Down syndrome, and there are some that we tend to see a little less. So and this is kind of in comparison with other individuals with intellectual disability. So there seems to be a higher prevalence in Down syndrome of depression, of anxiety and obsessive behaviors, and also dementia, which you already talked about. There seems to be a lower prevalence of diagnoses like bipolar disorder, schizophrenia, and also some of our impulse control disorders. Where I really want to focus today is on the depression and anxiety and obsessive behaviors, because that is what I'm seeing a lot of, especially in this kind of transitional age. So in terms of what does depression look like in Down syndrome, I think in the work that I do, when I see individuals who, with children and adults with neurodevelopmental disorders, that I'm sometimes meeting folks that are nonverbal or have limited verbal abilities. They're not able to tell me, Dr. Karlsson, this is how I'm feeling, right? And a lot of times I'm having to spend a lot of time talking to families, maybe talking to the school or staff that might work with them, and also really looking at behaviors and to try to piece together what's going on. But there have been some studies looking at what do seem to be the most common symptoms that present in Down syndrome. And so depressed affect, so that's kind of that like low down mood, social withdrawal, loss of interest and pleasure in things, a decreased energy, decreased appetite, regression in self-care, which a lot of times shows up as increased dependency on the caregiver. Problems with sleep, a lot of times insomnia, focus on physical pain symptoms and somatic complaints, and some increased irritability, aggression, agitation, and tantrums, and also some reduced speech. I have bolded and starred the different symptoms that some of the other studies that I listed below have seen to be the most prominent. So that social withdrawal, some of the regression in self-care, some of that focus on the physical pain and symptoms, and also maybe some increased irritability. And what often comes across as defiance and refusal, but can actually be more related to maybe an underlying mood disorder. One of the things that I feel like I see not uncommonly, and there's been certainly some written about this in the medical literature, is this getting, kind of these symptoms being diagnosed as early onset dementia. And we certainly know that there is a much increased prevalence of Alzheimer's dementia in the Down syndrome population. And I think a lot of medical providers are aware of that association. We learned about that in medical school. But early onset Alzheimer's really means more like, and in Down syndrome, after age 50, and more commonly even after age 60, right? So when I sometimes see patients that come to me and they've received an early onset dementia diagnosis at the age of 23, I'm really feeling like this is not likely to be dementia, and we need to be looking at other things. And really, the medical literature supports this. And now that we know more, again, we're seeing that the dementia diagnoses are probably more likely happening after age 50. And if they're happening, if these symptoms are happening under the age of 35, we really need to be thinking about other diagnoses. So what are some of the potential risk factors for depression and Down syndrome? Well, we know that there are some differences in brain anatomy that we see in Down syndrome compared to the general population. For example, people with Down syndrome tend to have a smaller hippocampus. Hippocampus is broadly kind of known for its role in memory, but it is also has been implicated in research studies in the development of depression in the general population. We also know that individuals with Down syndrome tend to have differences in their level of neurotransmitters in the brain. So when we hear the words chemical imbalance applied to mood disorders and things like that, we're thinking of neurotransmitters, and there have been studies showing that there are lower levels of serotonin and GABA and dopamine in individuals with Down syndrome, and certainly especially serotonin, but also the other two have been very closely tied with the development of depression. Cognitive function. I'd already mentioned that individuals with intellectual disability and even lower IQ in the general population have been shown to have higher rates of depression. We've also seen that gender may play a role, and that females tend to be more at risk for depression than males. Well, that's certainly not always the case, and males can absolutely have depression. And then I think the other thing that is a risk factor for everybody, but I include it as we're thinking about depression and Down syndrome, is stressful life events can precipitate an episode of depression. So this can include grief and loss. This can include medical illnesses, and they aren't necessarily huge medical illnesses, but in illnesses that may impact their functioning or quality of life for a period of time can certainly play a role. And then some of the other just big transition things that we were talking about, right? Going from maybe a high school that in a classroom and a teacher that you've been with for many years and a peer group, and maybe you're now not with that peer group anymore and you've had to say goodbye to some people that have been in your life for several years. Those can be really stressful life events that certainly can put you at higher risk for developing depression. I want to shift a little bit now to anxiety and obsessions in Down syndrome. Many of you are aware that some repetitive and compulsive and obsessive behaviors can certainly be part of the behavioral phenotype in Down syndrome. So what I mean by behavioral phenotype is that there may be a certain kind of set of behaviors that we see more commonly in individuals with Down syndrome. So this is also very much the case if we think about autism, right? So autism has a behavioral phenotype that can be, you know, increased restricted interest, repetitive behaviors, problems with social interaction, things like that. So we're talking about the behavioral phenotype in Down syndrome. And we may see it as actually associated with worries, especially in young children, but not necessarily related to a mental health disorder. So if you think about it, you know, sometimes maybe if you're worried about something, if there are any nail biters out there, right, we may engage in some of that kind of obsessive repetitive behaviors, or how many people when they're a little nervous are kind of tapping their foot, you know, doing some of those things. Also, you know, kids when they're a little nervous or worried about something, you know, they ask over and over the same question, right? When is this going to happen? When is this going to happen? My kids right now are very much like, when do we get to go back to school? When do we get to leave the house, right? All of those things, because they're a little worried and anxious about what's going on. So these are the kind of symptoms that for a lot of folks tend to improve with age. And in Down syndrome seems to occur at very similar rates to other intellectual disabilities, but probably a little higher than the general population in terms of the frequency and severity of some of these repetitive and obsessive behaviors. But these are also things that we see in children in the general population, right, that are typically developing. We can also see this, and again, tends to improve with age. What I think about when I'm thinking about a new diagnosis of anxiety or obsessive compulsive disorder, or maybe an exacerbation of some underlying baseline anxiety, is I'm really looking for a distinct change or worsening from baseline behaviors, or worsening or worries, and that's now really impairing functioning, right? So that's kind of going back to what I was talking about initially with those excessive generalized worries, or maybe developing some new specific fears, right? Like now I'm really afraid of the dark, or I really don't want mom to leave me. And maybe that wasn't an issue before. When I talk about excessive generalized worries, maybe really like worrying about leaving the house, or, you know, when it used to be really fun to go out and go to the grocery store. Also, it can be a real uptick in some repetitive and compulsive behaviors. And a lot of time what this represents is some of these repetitive and compulsive behaviors they're actually kind of being used to be soothing, right? I'll hear families say, yeah, they used to kind of do this when they were younger, but we really hadn't seen it be a problem for a long time. And now it's like they're completely obsessed with this, or they're, doing, pulling their hair out, or they're, chewing on their nails, or they're picking at their skin, or some of these other repetitive behaviors we might see when there's a huge uptick in anxiety. So, let's say you've gone to see a physician, you've gone through criteria, it's established, yes, we do think that, your loved one is experiencing depression or anxiety, and we have a diagnosis. Now what, right? What does that mean? And so I thought this would be kind of fun for us to go through and have some statements and do a little true or false. You can just answer to yourself. If we have some super competitive people, you're welcome to put it in the chat box. I will not be checking answers on the way, but wanted to go through and see what you guys think, true or false, about these statements. So the first one: individuals with Down syndrome do not benefit from talk therapies for treating depression and anxiety due to their intellectual disability. True or false? So that answer is false, and we will talk about that in just a moment. Here's the second one. Individuals with Down syndrome do not benefit from the usual medications that are prescribed to treat depression and anxiety. True or false? That one is also false, which we'll talk a little bit more about. And then studies have shown that individuals with Down syndrome and depression are often tried on multiple medication treatments if their symptoms persist or do not improve. True or false? This one's tricky. The answer to that is also false, and we're going to talk about why that's a problem. So when we talk about treatment options, and this is really for the treatment of depression or anxiety across the board in children and adults, is that when we're talking about mild to even sometimes moderate depression and anxiety, the first line treatment is always behavioral therapy before we move into medication treatment. So cognitive behavioral therapy, CBT, many of you guys have probably heard of this, is really some of the gold standard, most evidence-based treatment for depression and anxiety. And there was, in the past, kind of this myth that individuals with intellectual disabilities could not benefit from these type of therapies, but it's simply not true, in that many of these therapies have been modified for individuals with intellectual disability. And if you find, a therapist who is experienced with treating individuals with neurodevelopmental disorders, many of these skills are very modifiable and very, very helpful. And it's just important that that they're trying to modify the skills to match the current development and mental age of the patient. So for example, we have CBT modules, and when I'm teaching, my child psychiatry trainees, residents, we have CBT modules that are very much geared towards, very young children, 6 and 7-year-olds. It's really cute. It's a module called the Coping Cat, right? Well, teens, they don't think Coping Cat is cool, right? They don't want to learn about Coping Cat. So we call it something a little different, and we change the angle and things. And so they can really be modified to fit anyone's interest and kind of educational or intellectual level. CBT is all about identifying your thoughts and your feelings and your actions and how that's tied together. And sometimes it's just, working with folks to identify when they're starting to get stressed out. Some things that are added with CBT include, you may have heard terms like behavioral activation. So the therapist may work on how do we really engage your supports, right? How do we get some more help in here? How do we get you involved in additional activities, get you out of the house? How do we get you on a schedule? We know all of these things can be really, really helpful in the treatment of depression and anxiety. CBT is also really a lot about developing coping and relaxation skills. And sometimes it's not just on the patient to be the one recognizing, oh, I'm getting stressed right now. And we do this a lot in child psychiatry, where it needs to be, the child and the parents together that are recognizing, okay, it looks like you're getting a little stressed out right now. We're going to practice, some of the things that you worked with, your therapist in order to make you feel a little bit better and a little more calm. For individuals that are having more moderate to severe symptoms, so it's really impacting their functioning, and sometimes their symptoms are so severe it's impacting their ability to even participate very much in therapy. First line treatment for both depression and anxiety and obsessive compulsive disorders are selective serotonin reuptake inhibitors. These are also known as the SSRIs. They're first line. They are some of our most well-studied medications and safest and most tolerated medications in all of our psychiatric medications that we use. So some common ones probably you guys have heard of are fluoxetine, also known as Prozac, sertraline, known as Zoloft, but there are also many others. This is where, when I ask the question, how many people think, individuals with Down syndrome get tried on multiple medications? And the reason that I bring this up is that response rate to an SSRI for someone with depression or anxiety is about 40 to 60%. The first medication that people have respond and they have symptom resolution. That may not sound like a lot, but actually in medicine, that's a really good response to a medication, to have that good of a response. And there have been studies showing that in individuals with Down syndrome treated with SSRIs that have depression, more than 50% responded very well to the SSRI. So it's definitely something that should be tried if there are significant symptoms. But here's the thing, if it means that maybe 50% did respond, it means other people maybe didn't respond. And the message I want all of you to know is that we have many other options for treating depression and anxiety if there's no response to the first medication. And what other studies have shown is that individuals with Down syndrome often do not ever get tried on another medication. And, thinking about why this may be is, when compared to other individuals with intellectual disabilities, individuals with Down syndrome overall, this isn't the case for everyone, tend to have fewer what I would call disruptive behaviors. So maybe the big agitation, aggression, and things like that, that we sometimes maybe see in some of our other developmental disorders. And so sometimes, what happens is, okay, we think maybe this is depression, we're gonna try Prozac. They didn't respond. Well, I'm not sure, maybe that's just not what this is. And, and maybe everybody just kind of learns to live with it. The problem with that then is that, I think we're really having prolonged suffering for something that can be very treatable. So if someone doesn't have a response to one medication, certainly inquiring about what else can be done, what other treatments can we try, because we have a lot for treatment-resistant depression. Some of the things that I think it's important to think about if you do have a loved one that is not responding to the typical depression and anxiety treatments is, maybe there needs to be more looked at, more evaluation, maybe more medical workup needs to be done. So some symptoms that if, you've tried a few things that indicate further evaluation is needed is, has there been really significant functional decline, right? So you used to have, your child, loved one with Down syndrome, was very verbal and outgoing and now has complete loss of speech, right? Or loss of previous skills. They were very high functioning and they're no longer able to do. Have they had really significant weight loss, including maybe decreased fluid intake? Or they had changes in movement, or they're walking. Are they dramatically slowed in their movements? Do they have new abnormal movements? These may all indicate other things and, need more medical workup to really indicate what could be going on. I don't know how many of you guys watched House back in the day. House first came out around the time I was starting medical school about 15 or so years ago. And one of my friends and I used to always sit and watch it. The first couple seasons were really spot on. They had great medical writers and, it was really legitimate. After that, it started getting a little kooky. But we would always sit and we would watch. And if you guys remember, if you watched the show, House would someone would come in with all these bizarre symptoms, and they would sit around this whiteboard and they would come up with their differential diagnosis, right? Like, so when I talked about before, maybe they come in with shortness of breath, right? Well, there's a lot of different things that shortness of breath could be. And so they would come up with a list and all the tests they needed to do to figure out what was going on. So really, anytime someone presents to my office or to any physician, this is what we're doing, kind of with our questions, asking about history, maybe we want to check some labs, is that yes, you may check all of the check boxes for major depression, but guess what? There are a lot of different things that can cause fatigue, that can cause low mood, that can cause these things. And we need to make sure that we are developing a differential diagnosis and we're ruling out some of the other things before we just focus on one thing like major depression. So a couple of things that I wanted to bring up and focus on, because there's certainly higher rates of this in Down syndrome, is a couple of medical issues that can be real mimickers of depression. One of those is obstructive sleep apnea. So very high prevalence in Down syndrome. And one study looking at adolescents and young adults who presented with major depression showed that it was really common. So 44% of adolescents and young adults without major depression had a diagnosis of sleep apnea. And it was almost double that in adolescents and young adults that had Down syndrome and major depression. So if you think about some of the symptoms of sleep apnea, right? Fatigue, trouble concentrating, certainly can affect your mood. And what we know is that untreated sleep apnea, when you do have depression, untreated sleep apnea makes your depression much more difficult to treat. So this is, when I'm talking with someone, I'm getting a history, I'm also thinking about sleep apnea, and could that either be part of what's going on, playing a role, or maybe a reason that we're not responding to depression treatments, because certainly, as we said, you can have both. We may need to think about a sleep study. Another really common one is hypothyroidism that has a lot of the same symptoms of depression, right? So you can have weight changes, you can have fatigue, you can have slowed movements in speech, you can have weight gain, things like that. So it's, again, higher prevalence in individuals with Down syndrome, estimated to be about 15% of folks have hypothyroidism, and that this incidence tends to increase with age. So just another thing, when I'm first meeting someone and I'm thinking about labs, I'm usually checking a thyroid level to make sure that we're not missing that, which is, very treatable. One of the things before I kind of wrap up with some of my slides is I wanted to talk a little bit about quality of life, because I think for all of us, being able to provide high quality of lives for ourselves, our families, our children is really, really important. And it's, that can mean a lot of different things to a lot of people, but I think it's important to think about, especially looking in Down syndrome, what has been looked at about how we can measure quality of life, and what are some of the factors that really may play a role in quality of life. So there was this great study in Western Australia looking at some individuals, talking with individuals with Down syndrome between the ages of 16 and 31 in their families. And they had them do this questionnaire that has been used in research studies to kind of understand the impact on quality of life. And it's looking at a few different domains. So it's looking at physical health, it's looking at different psychological factors, it's looking at peer and family relationships, autonomy, things like that, and measuring quality of life. And what this study found is that there were a few things that were significant and stood out from the rest. So things that tended to have negative impacts on quality of life in Down syndrome was an overall burden of illness. So how much was going on in their physical and mental health really did have a negative impact on their overall quality of life. And the two things that were most significant was having untreated or undertreated mental health issues, and certainly medical issues came up, but actually GI issues was the one that really stood out. So this could be, abdominal pain, constipation, those, different kind of things. Irritable bowel syndrome, Crohn's disease. You guys are well aware of some of these different things that can be more common in Down syndrome. So those could have negative impacts. And then the thing that stood out amongst anything else for a protective factor was having 3 or more peer friendships. And, you know, I think that for it to be the one thing amongst many other things I thought was interesting, but it also makes a lot of sense, right? Because when we think about how important it is to have social support, and, you know, we are in the midst of the biggest study here during the pandemic on social support and its impact on all of our wellness, right? How connected we are, that's really, really important. So having that social support and some other things that have been shown in some literature around individuals with intellectual disabilities is that having, you know, jobs or volunteer work outside of the home, being in a day program, being involved in other things, having those other outside supports and social connections is really, really valuable and important on overall quality of life. And like I said, we know that these are important factors if you think about, you know, physical health and social supports are really important factors when we think about overall well-being for and treatment of depression and anxiety. So some of the final points that I wanted to make before I wrap up here is that we know that transitions can be challenging, and for individuals with Down syndrome, they can also be challenging and sometimes maybe create some additional risk factors for developing depression and worsening anxiety. Depression and anxiety can be common in Down syndrome and likely higher than the general population. And we also know that mental health disorders tend to be underdiagnosed and sometimes misdiagnosed in Down syndrome. The diagnosis of psychiatric disorders in Down syndrome certainly requires a thorough medical and psychiatric diagnostic evaluation to make sure you're thinking about that differential diagnosis, you're getting a really great history, and ruling out other medical problems that could be contributing. And then depression and anxiety has many safe evidence-based treatments, but unfortunately many individuals with Down syndrome do not always receive adequate treatment. And so, you know, as families and caregivers, if you feel like your child is not improving, is not responding and things like that, being persistent, that, you know, that to see if something else can be done or some added supports is always really important. With that, I wanted to share some information about the clinic that I have at IU Department of Psychiatry. So like I said, I founded this clinic several years ago now, and we specialize in the evaluation and treatment of children, adolescents, and adults with Down syndrome in psychiatric and behavioral concerns. So I'm the psychiatrist in the clinic, and the psychologist is Dr. Jill Fodstad, who has extensive experience with behavioral therapies treating children and adults with developmental disorders. There are numbers you can call to schedule an appointment. I did also want to let you all know that we are participating in some national Down syndrome research studies. I did tell Stephanie I'll get some information out as it comes out in the next several months. Again, this has been delayed by the pandemic like everything else, but we'll be participating in a national research study looking at Alzheimer's in Down syndrome, and certainly we'll get that information out to Down syndrome Indiana. And lastly, wanted to leave you with one more painting to enjoy that's a little different still about the transitions, and happy to take any questions in these last several minutes.
Thank you. That was awesome. So I actually typed the first couple questions in the box because I was so afraid I was going to forget. I love that you mentioned it's just the Down syndrome thing, because I think any parent of a child with Down syndrome has heard that.
Mm-hmm.
And not necessarily just from a mental health care provider, but a lot of medical providers say that as well. So this is maybe out of your wheelhouse a little bit, but do you have any advice for how we as parents can deal with that statement, how we can better and more effectively interact with our providers to kind of help educate them and encourage them to look outside of that one single diagnosis?
Right. Well, I think the one thing, as I have, you know, since I have started the Down syndrome clinic and gotten to know so many families that have children with Down syndrome, is that this is a very educated group of parents who are often great advocates, very knowledgeable about, Down syndrome and both the medical complexities that can come with it, as well as some of the psychiatric complexities. And I think sometimes it really goes back to, that, and I always feel this way, that, I went to medical school and this is my specialty, but you're the expert at your child. You're the one who knows what their baseline is and what changes there are. And I would say, if that kind of, because I do feel like it sometimes happens in a dismissive way. And sometimes I think it can be really valid that there, are, like you said, there are some things that are very, well established and known in Down syndrome, but I think sometimes it can be done in a bit of a dismissive way, which I think some of you guys have probably experienced, where there's not a lot we can do. And I think, and I see this, since I treat a lot of patients with autism spectrum disorders as well, it happens there too, right? Well, this is just the autism, right? And I think just because, even if it is, for example, a part of maybe the behavioral phenotype that we talked about, it doesn't mean that it is completely too immune to responding to interventions. There are things that we can do. There are therapies that we can do to be helpful with that. And so, I think just kind of coming back and saying, yeah, I know that can happen in individuals with Down syndrome, but what I'm seeing is a very big change for my child. And I'm concerned about these changes and really being an advocate that I know many of you guys are.
That's awesome. That is a good way to handle it. My other question, kind of as a mom and as a professional, so I get calls from parents of adults with Down syndrome fairly regularly, and I've heard from some people who are really, really concerned about the self-talk that their kids or adults do. And I know with my daughter at 8, she talks herself through everything.
Mm-hmm.
It's like she has imaginary friends, like she just
Mm-hmm.
carries on conversations and does different voices. And I saw in your slide that like schizophrenia and bipolar disorder are not as common in individuals with Down syndrome. So how do we as parents kind of navigate that? What's typical like self-talk for a person with Down syndrome versus potentially something that we need to have addressed?
Sure. So it is really common, and that we do see a lot. And sometimes it's actually a really fabulous coping skill that kids come up with, some of the self-talk. And, I know Dr. Bull, who many of you guys know, of course, very well, talks about this a lot. And that, it can be a way of kind of working through. And this is something that kids do a lot. And kids will do it in different ways. Sometimes kids do their working through in their play, reenacting something from the day with their Legos or their, whatever. But a lot of kids also can do it with talk. And I think for some kids, they maybe keep that as an internal monologue, right? And there are some kids that are more prone, and I think sometimes we do see this in individuals with developmental disorders, that it's more externalized. So it's still that internal monologue, right, of like working through what happened through the day or what I'm thinking about, but it's vocal and it's external. And I think, for some kids, and you guys may notice the difference of when my kid gets home from school, they want to go to their room, and for the next hour, we're doing lots of talking, and maybe it sounds like a back and forth conversation, right? And maybe it sounds like friends or things like that. A lot of times that's kind of that chill time, and they find it relaxing and comforting, kind of some of those other like obsessive repetitive behaviors I talked about that are actually a coping skill. So for a lot of kids, I think it's actually a coping skill, and adults too. Sometimes we may see increases in that when people are stressed out, right? So it's kind of like all those other coping skills, like I'm going to bite my nails more when I'm stressed out. Sometimes that can be times where the self-talk goes up. When I might get concerned about that this is something different, right? Does it have a really different quality? Is there more kind of delusional content to it that doesn't make sense? Does it, seem to be a very scary experience for the individual. I will also say that sometimes people can have some of these experiences that almost seem like hallucinations that really are related to anxiety. Actually, the number one reason children experience things like voices is anxiety. And people that have psychosis, it's often usually not limited to just having some conversations in their room. It's much more pervasive to where there are kind of delusions, confusion, things like that in much of the other areas. So those are some of the clues that I usually look through to kind of let me know which direction that it's going in.
Excellent. Thank you. So we have a mom who said that, oh, my chat box just changed. Got a mom who said that her daughter tends to lose it when her routine is disrupted. Is her reliance on that routine considered a compulsion?
So I guess I normally probably wouldn't consider that necessarily a compulsion. I think that there is often a lot of reliance on routine. Kids in general tend to do really great when we have routine. I mean, and some of you, there's got to be some people out here that like the same thing for breakfast every day, right? Because that's your routine and you do it. We like routine as humans. But I think that sometimes when there's difficulties in navigating, what does a change mean? And a lot of times it is really not understanding, well, what am I supposed to do when this changes? What's going to happen to me? Well, what's going to happen next, right? And there's some of those worries that come up with, I imagine it's sometimes kind of like if I was dropped off in a European city where I didn't have a map and I didn't speak the language, I would kind of freak out and lose it too, right? Because I wouldn't know what I'm supposed to do, what's going to happen next to me. So a lot of times there can be, and sometimes you hear the word rigidity about changes in schedules and things like that. And that's one of the things that, probably could get thrown in just the Down syndrome or just the autism thing, but actually something that can be really responsive to working with a behavioral therapist on helping your child when they're experiencing struggles with change in routine and make that an easier experience for them.
Excellent. All right, the next question is, have you heard of targeted nutrition intervention, TNI? They have a recovery protocol for people with Down syndrome with big regression. They also have protocol for all people with Down syndrome to treat with supplements. Nutravine D is familiar, one of the familiar names of the vitamins. So she's just wanting to know if you're familiar with that and if you use that at all.
So I have heard of it. Is not something that I use in my clinical practice. In terms of kind of the evidence base for treating some of these symptoms with some of these supplements, it's really just not as strong as some of the other treatments and interventions that we use. And I think twofold, I worry about that with sometimes using supplements is that we don't maybe have strong evidence that it's beneficial. Maybe and sometimes we have different levels of evidence. So there's anecdotal evidence like, well, I gave somebody the supplement, I gave one of my patients the supplement, or my friend's, family member took it and they got better. So that would be anecdotal evidence. And then we have really high levels of evidence that say we had randomized controlled trials with large numbers of people and we were able, because a lot of times what's shown in really tiny studies or this anecdotal evidence doesn't actually play out when we do it in much larger numbers. And so so there's that aspect as, is it beneficial? The other thing is it potentially harmful? And that's the other important things that come out of some of these larger studies. And where I said, we have some gaps, certainly in specifically depression and anxiety and Down syndrome, a lot of the medications and treatments that we use, we have really, really great safety data when used in other populations, right? So we know a medication's kind of safety profile, or we know that, this therapy intervention has been, shown to be effective in lots of people. And so that's where my concern as a physician comes in. And I'm not saying that these things don't work or they're not helpful or that in 10 years, I won't also be prescribing them. It's just at a kind of a level. And this is my same thing with CBD oil, right? Is that, or at this point, we have great evidence that it helps with this one particular type of seizure disorder, but we don't have as much evidence in other things, and we don't have long-term studies showing us that it's actually safe and it doesn't harm your child in any way.
All right, well, thank you. So we've got another mom who said her son actually sees Dr. Dunn at Riley, and she also works for About Special Kids, and she's curious about how to help direct the many families that can't easily access mental health treatment due to distance or lack of transportation. Do you have any info on, like, if families live a distance from Riley, like, to come to your clinic? Is there an overall mind shift in community mental health providers to be able to provide therapy or med management for this population? Like the teletherapy. I'm really hoping that teletherapy to some level continues post-COVID.
Yeah. Well, if there can be a silver lining to some of the pandemic, I really think it has been really the kind of explosion and wide acceptance of using telemedicine, and really out of necessity. And here in our department of psychiatry, there was a little bit of telepsychiatry and teletherapy and things like that happening, and we were forced to really, in a matter of a couple weeks, turn a mostly in-person practice to entirely telehealth. And actually we were the first department at IU and amongst all the departments to reach our pre-COVID numbers. And we did that very quickly. And I think that's because psychiatry and therapy actually translates quite well to some of these telehealth visits. And I know that I certainly had a lot of families say, oh my gosh, I really hope that this continues, because driving 3 hours to see you in Indianapolis is really challenging. And so I think that certainly our department has recognized that. And I think the plan going forward is to likely have a mix. There are some people that it's really important that I see them in the office, that I'm doing a physical exam, that I'm getting their vitals and other things like that. But I don't necessarily need to see them every time. And I know that Dr. Fodstad in our clinic and many of our other therapists are doing a lot of their therapy appointments online. And one of the cool things actually that some of them have seen is that they'll talk about maybe really anxious, children or things that they've seen that maybe won't utter a word in the clinic, right? But they've found that via Zoom, sitting in the child's own bedroom or things like that, they're very open and talkative and excited to show things. So I think we've also seen that there are certainly certain populations that do even better. And for me, it's been nice to sometimes see some families and patients in their environment, and that's been really nice too. So absolutely, I'm hoping, and I know that it will continue. And currently now I'm seeing even new patients via telehealth. As far as availability in the community, I'd say there's still a lot of variability in folks' comfort levels in treating individuals with really all neurodevelopmental disorders, both from a medication standpoint and a therapy standpoint. But there certainly are some at some community mental health centers. I would say families should just probably call and inquire and ask if the provider has experience treating patients with Down syndrome or whatever it might be, and kind of go from there.
Yeah, and the second part of her question kind of relates to that exactly, right? Like I think we all see this. There just aren't a lot of folks who are comfortable seeing our kids. And she said that families are often told that, clinics can't see our kids. They can't even be evaluated or get services because of an autism diagnosis or a Down syndrome diagnosis or an intellectual disability. How do we combat that? How do we change that, I guess?
So it's certainly very challenging. And as someone who, this is kind of where I've chosen to specialize and focus, it really, makes me sad and breaks my heart that a lot of people are excluded based on these diagnoses. And so some of the other hats that I wear in my work is that I very dedicated to medical education, and I'm the training director for the Child and Adolescent Psychiatry Fellowship here at IU. I'm also the training director for the Triple Board Residency Program, and even one of the associate training directors for our adult psychiatry program. And some of my mission is actually to graduate, providers, psychiatrists is what I have my role in, but that are comfortable treating children and adults with developmental disorders. And I really feel like, and I think what I often see, because I am someone who will see adults both with autism, Down syndrome, things like that, is that a lot of adult psychiatrists don't have a lot of experience, treating adult population. And as we all know, these diagnoses don't go away at age 18, right? But a lot of the supports do. And a lot of the providers that are most comfortable are child providers, right? And so certainly that has been a huge mission in our department, is to increase the knowledge base and to continue to do things like this and work with, not only working with DSI, but working with the Down Syndrome Medical Interest Group nationally to really provide education and increase research and really knowledge about working with individuals with Down syndrome.
Excellent. So we got one more question that just came in the chat box. So are persons with Down syndrome more likely to exhibit OCD-like behaviors? His son, for example, has been really attached to certain objects like toys all of his life. And even now at age 21, he's still really attached to those items.
Yeah. So when we kind of go back to some of the behavioral phenotype that we talked about, that is one thing that has been identified in some of the behavioral phenotype in Down syndrome is some connections, some maybe obsessions about certain things, which I call OCD-like, meaning that there may be some specific obsessions and interests, but maybe they don't cause significant functional impairment. There's something that seems to bring the person pleasure and joy, and they just really, enjoy and like that. I think the difference would be, whether we're so focused on the specific toy and doing that we really can't do anything else, right? Or we can't have these other interactions. And even in those situations where, maybe some of the obsessions can start becoming all-consuming, that's also a great intervention for behavioral therapy to kind of how do we maybe decrease the dependence on this certain toy if it is causing a problem to allow you to experience and do other things. But absolutely, I see it very commonly.
And so second part of that question, is there a good source for understanding the typical Down syndrome phenotype? Is there a source you recommend?
I'm trying to think if there's a specific paper. I know that there is on some of the National Down Syndrome website, I believe there are some sections there about some of the behavioral phenotypes seen in Down syndrome. I'm off the top of my head, I'm trying to think of a specific paper, but I'm also, if you would just Google Down syndrome behavioral phenotype, I'm sure it would pull up some things that talk about some of those specific areas. But those obsessive behaviors certainly are something that we see commonly.
Okay, well, it looks like that is all of our questions for now. So Dr. Karlsson, thank you so much. This has been really, really great and very informative. So we're
absolutely, the pleasure is mine. Thank you so much for having me, and please certainly reach out to me if there's anything that I can do to help.
Excellent. Well, thank you all for attending, and hope you have a great Thursday evening.
All right.